and welcome to this new year, new institutional activity. On the stage, I welcome Professor M.K. Garg, Professor Sandhu, Professor Jha, Dr. Naveen Sharma, and all the faculty members from the institute and all the residents. We welcome you to this very important but again stimulating talk come panel discussion about what we are doing at our institute as an academic activity. So basically this was targeted for the PG students, senior residents, PhD scholars and all the students and interns. They have been asked to attend this, although today was a foggy morning and a lot of fog and the cold is also there. So there is a probably they are going to come. But let us start because this is our commitment that any activity should start at 8 o'clock and end at 8:45. So the talk or the CGR or the activity is about looking back to move forward with quality and excellence. So I will share you with some of our objectives. These are how the evolution of the clinical or medical grand rounds have occurred and the common institutional activity at our institute. Some of the reflection on the past, what we have done, what we have achieved, and also guidelines for improving the quality. This objective will be done through a panel discussion. So we have a lot of lively discussions. There is interaction from all the participants to ask questions, to suggest ideas, and comments on something which can be improved on the quality. So this was the days, there were days when the examination was performed by the side of the patient bedside and whole of the team of the doctors were there. And this opportunity was used for demonstrating some of the important practical aspects. Then in 1901, the American Journal of Medical Association, they published a natural method of teaching the subject of medicine. And they outlined there are 3 stages. One is that learning about the anatomy and functional part of the medicine. Second is the learning about the disease part. And the third was applying those knowledge for managing and preventing the disease. So this is a part of the MBS curriculum as well. So classical or traditional grand rounds were about how the patients are there in the ward and they take the round. And Sir William Osler introduced the bedside teaching as a new approach in those times. And these rounds gradually moved from a bedside to an auditorium. And the traditional approach to the grand round was created. So this was the change of the pattern of the grand rounds, that is moved to the auditorium. The patient is also there. But nowadays the patient is also vanishing from the grand rounds. And the traditional grand rounds were well organized, decorous, stately, and punctual exercise. And the patient is the theoretic focus of all clinical activities. However, the Socratic dialogue of dealing with the patient directly in the bedside gives way to the PowerPoint. So we are having this PowerPoint. And now this paved way to the present format of sitting in the auditorium and having the talk. AIIMS Jodhpur started the institutional activity in 2014 in January. This was after a lot of deliberation when the OPD was started in July 2013. And when the patients start coming, we thought of that we have to some discussion about the patients, unique patients or something unique about the patients, so that every resident is apprised of that and we can also inculcate the same habits among our students. So this was the first committee. Dr. Arvind Sinha, Pramod Sharma, Vanita Lal were there. And first CGR was presented on 17 January 2014 by Dr. Neeraj Gupta, who is additional professor in pediatrics and neonatology, of a case of suspected fibrosis. At that time, there was no investigation available except for the basic investigations and the radiology. Then we also formed the CPC committee headed by Dr. Silajit Bhattacharya, Poonam Helens, Pushpinder Khera. And first CPC was on 19 January by Dr. Ram Karan Chaudhary on a case of a lung cancer and discussion by Dr. Poonam, Pushpinder and Puneet. So this was a departmental presentation. This was an anatomy department. Dr. Shilpi Dikshit, she is presenting very important topic. Actually, we were not aware this is something known as plastination. That is how we can preserve the human body exactly at it is And the process of preserving the organs in a similar way like a normal person is known as plastination. So she discussed about the various techniques of the plastination, and then Dr. Nayyar discussed about the preservations of the various museum articles in the anatomy. So this was also a very interesting thing. Then Dr. Nayyar and Dr. Pankaj discussed about the medical certification of the cause of death. Now we have a huge list of these CGR, CPCs, which are all available on the YouTube. Except for those, there was some issues in they cannot be disclosed on the public fora. Some of these are also available privately. So on the request, they are provided because they are uploaded, so they can be given to the faculty. And these are some of the glimpses of our CGR on different aspects of medicine. The adrenal angle, a small gland with big impact. Thoracic duct embolization, orientation from the Institute Hospital Infection Control Committee. And sometimes the CGR were like that they excited or elicited the interest from multiple departments. For example, PCOS, having a varied clinical spectrum seen by even endocrinologists, dermatologists, and gynecologists. We also have the guest speakers, Professor Manjeet Bains from USA visited, and he presented very well about his experience in just 35 minutes. We also started a newsletter for clinical grand rounds, and this was a guest lecture. Then we have a orthopedics, they had presented the CGR on journey so far. Dr. Naresh discussed a very important topic of depression, fighting blues. And this was a topic on the palliative care by two departments coming together, community medicine and the radiation oncology. And these are the other important topics which has been discussed. So with this varied type of presentation from different departments, right from the anatomy to the neurosurgery, we also had the opportunity to move from places to places. So we started our CGR in a biochemistry demonstration room having a limited seating capacity of around 65 to 70. And it was fully occupied, crowded. And then we moved to the lecture theater one because the residents start joining, non-academic junior residents. And then we start, because now the new fresh batch has also arrived, we start moving upward to the LT3. Then we moved to the e-classroom. And since 2017, we are in the auditorium, the present place. But the COVID time, we also had an opportunity to have the online CGR, CPC, and mortality meet. So clinical rounds during the COVID also exposed some of the important aspect of the medical education as well. Updates on the COVID testing, COVID and different conditions like pregnancy, elderly patients, COVID among children, COVID for the school banning, lockdown. All these aspects were discussed during the online CGR and CPC from 22nd July 2020 onward till the end of 2022, January 22. Now the current situation is that we have marked improvement in all the institutional activities, and credit goes to all the faculty members. Proactive presentation from many of the faculty, they've just wanted to present their cases. For example, radio diagnosis, they are always asking कि हम लोग का turn कब आएगा. So these are the things which are there, and they have a lot of cases also. But again, the problems of the times and other things are, and because of our schedule, we are preventing them for presenting. Multiple types of activities were also introduced, like clinical grand rounds, clinical pathological conference, mortality meet. We also introduced morbidity meet and guest lecture. Changing methods we have observed, simple from the biochemistry where the PowerPoint presentation were projected, even the blackboard were used, to the innovations in different methods like using the panel discussions for presentations, for the mortality meets, to having the groups of people coming together and presenting there in a form of clinical burst. Then presentation styles also changes markedly during last 8 years. So now we have come to a stage that we can say that our institutional activity is highly mature, but only there are some challenges which I will discuss after this panel discussion and the presentation by the Pediatric Surgery Department and Department of Medical Education. So this is a case will be presented by Dr. Motiwala.
What we are going to do here is how we do our M&M meetings in the Department of Pediatric Surgery. We are refining it over a period of time since we started. So we wanted to share how we do it and whether we can improve it, or we can get inputs from others, and we can also be able to show a standard format of presenting an M&M. So our resident Tanmay, who's in final year SR now, he will present the way we present in our department, and then we'll open the discussion by the panelists.
Good morning, everyone. So, audit is something, or M&M is something I feel that it is the patients that teach us, and if we don't pay heed to the mistakes that we have done, then we are bound to repeat it. So, this is a general format of the M&M that we follow, wherein we discuss the total IPD patients that were admitted during the month. This is a monthly exercise for our department. We go on to see how many were elective patients, how many were emergency patients. Then we go on to see how many were operated in emergency OTs, how many were non-operative managements, and how many were postponed, and for what reason they were postponed. Then we take a look at the outcomes, how many were mortalities, how many were morbidities, if there was any leave against medical advice, if there was any transfer, and there were any discharges. We take a brief look at the system-wise distribution of cases in our department, as we basically are from pediatric surgery, so we take a look at hepatobiliary, genitourinary, GI, trauma, oncology, thoracic, and this just gives a brief idea of the majority of cases that are coming in our department. Then this is followed by some of the noteworthy cases that we have during the period that we are discussing, so that everyone gets to know what our in the department, what are the things that we are doing, or if there is something interesting worth discussing, then it is discussed in our departmental meet. So this is just an example of the same. And this is something we discuss. This is Codman's classification. While we discuss the mortality and the morbidities of the cases, I think this is something that has helped us evolve as a department to correct our overall, patient care. So this basically consists of, you can see that there are 3 columns in there. One is error in judgment or diagnosis, one is error in technique, one is system failure, and the other is patient factors. The other is, was it preventable? If it was potentially preventable, or it was straight away preventable and something was missed, and the other is it wasn't preventable. And then the third thing is, what is the level of harm? It is very important to understand what is the level of harm being done, which happens. So it is not due to error. It may be due to some unavoidable factors. Then it may be due to some circumstances with capacity to cause error. There was some activity that was planned, but it did not reach the patient, but did not harm. Then it reached the patient, but required monitoring. There was no harm. The other is, there is temporary harm which required intervention. The other is the temporary harm which required hospitalization. There is permanent harm. There is required intervention to sustain life, like resuscitation, and then there was something which contributed to death. So any case that comes to us that we discuss in the mortality or the morbidity is classified into this, and then the discussion goes on from there. And then we again classify this into 3 factors. Why was this particular event occurred? Is it because of the human factors, or is it because of the system factors, or is it because of the patient factors? And this is just an example. So this is a modified fishbone diagram showing the course of the patient who had presented to us, then had multiple intubations. Not going into the detail of the case that was there. So you can use this preformed, diagrams are available free of cost online, where are different modifications of this fishbone diagrams. This gives a clear idea, it doesn't crowd the information that is being delivered. And once we have discussed the presentation and the course, then we decide, like, what was it according to the Codman's classification. So the presenter who is presenting the case, or the person who was involved in the treating, in the part of the management of the patient, will try to fit in whatever the circumstances were in this Codman's classification.
As Tanmay said, we can classify every mortality or morbidity according to Codman's classification. This way we have data of few years now where we know, are we doing more error in judgment, or there are more system factors, or there are patient factors, and it gives us a data to improve in future. So you can actually have for your 1 year, 2 year, and you can see at what level the M&M, your problems are happening. Was it, are you making too many errors in judgment, or the system factors are there which we as a department or the institute are not able to address properly? You have a data of so many patients. Like suppose we discuss like 4 to 5 patients every month. That way we have like lot of patients for a year. Now we have like 2-year data, and we can go back and see what exactly is happening. So this is what is followed at most of the centers where I had worked before, and we tried introducing it in our department. And this way we are able to discuss with our colleagues, that with each other's patient, that what's happening there, and it's an open discussion. There is no pointing fingers at us, because mistakes do happen. That we have to always, M&M discussions are to improve. So mistakes do happen. If you say we don't do mistakes, then we are God. But if you keep doing the same mistakes again and again, and if you don't learn from your mistake, you're a devil actually. So this is what we wanted to discuss before the panelists, and then I'll request Naveen Sharma sir to proceed.
Thank you, Dr. Kirti, Dr. Tanmay. We'll just open up the discussion to this panel, and I'll ask, I'm sure most of us do conduct quality improvement meetings among our departments, and then there are certain of those mortalities and morbidities that are presented at the institutional fora at the time that the roster allows you to do so. So we'll start with Brigadier Sandhu as to what his experience has been regarding the quality improvement meetings. And it's now customary to call these quality improvement meetings just so that the focus shifts towards improving in quality rather than pointing a finger at why exactly this mortality happened and who was responsible for this, and to broaden the scope of the discussion to improve things so that similar things do not happen in the future. So I'll start off with Dr. Sandhu.
Thank you. So regarding quality improvement and improving the standard of care that we are providing to the patients, I think it is a daily process, and it can't be just restricted to having meetings. It is a daily process which starts with the bedside round and the OPD and the operation theatre, post-op management, grand rounds. So it is a constant process, and one must be aware and point out to our colleagues and juniors if there is something which needs improvement. Not only to our colleagues, juniors, but also to the other staff that we are working with. Because many a times we see that there is a lot of scope for improvement in various procedures and processes. And it is a constant ongoing process which we must rigorously follow. In addition, this is in addition to what Dr. Kirti has already mentioned, which is a very good way of conducting an audit in the department. And I hope other departments, including mine, will be able to follow this example. Thank you.
Dr. Garg, your inputs on this topic?
Input is that death is inevitable to every one of us who are sitting here. Where it happens and why it happens, nobody knows. Hence, death will occur in the hospital, mostly in the ICU and medical wards. And definitely, we all want to prevent death. But never, as a resident, curse yourself if somebody dies. What has to be done? That you must do your best. And as has been pointed out, some type you must have the introspection to look if we are going wrong somewhere and whether it was correctable. As a medical student, as a junior resident, I know in the ward, bed number 25, case of MI, 14 days, about to be discharged. We are doing the round with professor. We move from 25 to 26. Tell 25, you are discharged. And next moment, he's dropped dead. Everybody's there. Nobody's fault. It do happen. Still remember bed number 42, a case of the liver abscess, shock, and I do the liver aspiration, no ultrasound at that time, somewhere in the 1983. Person blood comes out, I get feared, I run away to my hostel room. That patient attendant will come and beat me because patient is surely to die. Evening I come, everybody touching my feet, कि सब आपने गंदा खून निकाल दिया, patient बच गया. These all the instances do happen which nobody has the control. But as has been pointed out, that these exercises should not be done to point out anybody's error. We all sitting here have done the error in the life. Nobody is exceptions. If you are doing the work, error is bound to happen. And as a resident, you should not be feared that you have done the mistakes. Don't worry. Your professor has done the more mistake than you. But always come and tell, sir, this has been done. Accept those mistakes and try to do not repeat those mistakes. And never think that you have done the mistake and somebody is going to throw you out of here. You should not do harm to the patient. That is the very, very most important thing, that knowingly you must not do the harm. And when I use the word knowingly, it comes from the knowledge. You must gather sufficient knowledge. And if you don't have the expertise, please call on the seniors and don't jump first time to do certain procedure which you have not done supervised. So always call upon your seniors. Say, sir, I have done the one catheterization I was doing as an intern. And I've seen urologists putting some metal things and it was not going. And I tried it and there was a profuse bleeding. I had to call the surgeons. So, these kind of the things, that heroic things, as a youngster we do the mistakes and we learn from the mistakes. Medical science is not perfect. Everybody does the mistakes. So always do the introspection. Try, go, read, come back and learn more. Make yourself as perfect as possible. This is the one aspect of the audit. Since we are doing the CGR and topic is moving forward, way forward. And I will request Dr. Kuldeep Singh that we are doing so many CGR and CPC twice a week, almost 100 in a year. And to improve the quality, we can choose certain things and we can make a book kind of a thing or publish something as a book. So it will be useful to all the coming generation, what we were doing, and useful to outside world also, that how it is done. Even though we do the case presentation in the departments, we can collect all those cases once a year and publish your medical books or pediatric surgery books or surgery books, which has been done in the West. So documentation of such things will give incentive to write. It will improve your skills to analyze the things, and it will benefit others, and we all will learn from those things. So that is one way to improve the quality services of the CPC and CGR means. I tell that's what sir was telling. It is not that we must present all difficult cases. Simple case also teaches you much. Even the simplest case, I tell that you go and see. There will always be some variation because no books can write all things of the disease in the books day by day. They can only give the framework. And as a resident, you see the case day by day. That's why you are here. Because books cannot teach you whole disease spectrum. It is when you see, then only you learn. So one is the learning in the ward, second is CGR CPC, third is documentation, and fourth is the audit of self and department and institution. This all can lead to the improvement in the quality of the services. Thank you.
That brings up a very important point that Dr. Garg has pointed out, that it's up to the leadership of the units or the departments to provide that enabling environment for people to come out truthfully with the errors that have happened. and not brush them under the carpet and try to hide these events from happening. So different units practice different frequencies of having this quality improvement meetings. Some consider that daily rounds are a quality improvement meeting. Some people formally do it every month. Some people do it formally every week. We tend to follow it every weekly schedule. On Monday mornings, we audit everything that has been happening in the last week or so. So this is what we've continued for the last 6 months or so. But it is important for the leadership of the team to enable that environment that finger pointers is actively discouraged, and the aim of the meeting remains to improve the quality and not to have similar errors in the future. Dr. Jha, your input, sir.
So it was interesting to see how Dr. Kuldeep shared the history of evolution of the CGR in such meetings. So it is important to do some sort of audit, we all do in departments, and keep records of those audits. CGR is an extension of such departmental activity. So history, clinical skills, and anatomy, these are the mother of medical science. In the department, it is the best place to honestly express our faults, mistakes that we have committed, because we keep on learning lifelong. Every month, suppose we treat 100 patients, definitely somewhere we were not up to the mark in 20, 30, 40 cases. And we discuss it. It happens everywhere, at the best of the institutions. We keep on learning things at our department by honestly accepting what we could have done and which we didn't do. So the similar thing is happening here also. It is a form of audit. All the records of departmental activity is kept. I know that it is being done in most of the departments. That keeps a record, and that helps in coming generations, will be helpful for coming generations also. So similarly here also, we can share our honest problems, failures, and successes so that we learn from our mistakes done in the past. And the part that Dr. Kuldeep showed, we have just go through the CGRs like just Dr. Kuldeep showed Ostler's name, human plastination. So these CGRs are excellent because 1901 to 1945, 2 world wars happened. And how medical science evolution happened in medical science, basically in anatomy. Ethics matured during that time only. So ethics, anatomy, how did it mature? Then human plastination. So now human plastination, you see the Von Hagen's website. That is the human plastination website. So if we see our CGRs only or our departmental activity in past 2 years, 3 years, that is a bank of knowledge for others who will be joining here. So honestly expressing our mistakes, our successes, our learnings, honestly, because nobody is above the knowledge, never ends. So I think that will be the way forward for us to further grow.
So I'll open up the talk to comments from faculty members on the floor, even residents. Anybody who wants to share his inputs, how they do it, how we can make it better, I'll be happy to have your comments and suggestions.
I'm audible? Yeah. Good morning to all of you. I think it's a very good topic to start the new year with on a cold winter morning. And congratulations to Dr. Naveen and Dr. Kuldeep Singh for bringing this up. So just similar to what Tanmay presented, we in radiology, apart from the interesting case discussions that we have from the diagnostic point of view, we also have a DSA grand rounds. So we give, a description of how many patients were admitted during that month or that 2-week period, how many went to ICU, how many mortalities were there, and how many, OPD cases were there, all that we do in that. And because the audit is important to not only minimize the complications, it's also to tell the next patient what is going to be the likely clinical success or technical success of my procedure. I may be able to open up an artery, say in 80% of cases, whether it will going to translate into a clinically relevant use to him or her, that's a separate thing. And then also the mortality that we usually quote is from the literature. But what is it in our department? That we'll come to know only if we do audit of our previous 3 years and tell, okay, maybe this complication rate is close to what is there in the literature. Maybe it's a little more because we've just started our practice, or maybe it is better than what is there in the literature. So that's very important for patient counseling. Secondly, I think nudge can be there from dean's office, but I think in a mature institute like ours, the department should be open to the audits being open house. Interdepartmental exchange of ideas or inviting faculty from the other department who may have overlapping interest in the same domain should be actually encouraged and should not be curtailed just because, I think we are beyond the point of finger pointing. Finger pointing will always happen with some people, but you can't, use that as a excuse to stop the exchange of ideas. Because what I may do, somebody may do better, and if I think that is the case, I should refer the patient to him or her rather than doing it as a guinea pig. Then, from the diagnostic point of view, it's very important that the re-examinations that we do should be curtailed. CT उसका हो गया, उसका फिर दोबारा बुला रहे हैं हम कि पहले ठीक से नहीं हुआ था. That has to be done at a departmental level. I think that's what all the diagnostic departments have to look for. The re-examination rates or the resampling has to come down. And also, it's very important, the radiation exposure, it is, it should be actually necessary to image the patient, especially when ionizing radiation is involved. So that is another aspect of diagnostic radiology audit that we need to do as a department. And as I said, these meetings can be open house, and I think the Dean of Int can take initiative to circulate the roster so that anybody can, if when we want to attend the other department's meeting, we can do so. It's my view on it. Thank you.
Thank you, Dr. Khera. Any other inputs from the floor? Yes, Dr. Subit.
Morning, everybody, and thank you for the brilliant presentation on the panel. I believe, apart from generating why we are having that complication and the rate and the getting an audit and data as well, I think another important facet which I think sort of gives it a more positive twist to it and it helps calm yourself when you're doing that departmental meeting or presenting it out here is to come out with the learning point, really. I mean, all the mortality and stuff, they would be in two cases. One would be a highly unexpected error, and one would be a sort of a pattern, something that's small thing that's been happening maybe quite often or should not happen, not so happen. So I think the idea of coming out within the mortality meet or morbidity meet within the department and then presenting it out here should be that learning point, that one error, that one systemic thing that we could change, because that is what is important to the everybody in general, that let's not repeat that again. And also letting people know about that one unexpected error that happened, to just watch out for. You really can't prevent those, but you can watch out for those. So I think that gives a very positive spin to it rather than just the data and the statistics, kitna complication hua and it was that rate. It gives a very positive spin to it. Thank you.
Thank you, Dr. Sumit. So in addition to the background data, we also come out with talking points as to the learning points. And what you brought about was that the choice of case that we actually present here is vital, because if we are able to trust each other that we will not be hanged in front of the audience, we'll be able to bring out cases which actually teach us something rather than cases who've been lying in the ICU for 3 months and in whom the death was essentially non-preventable. So my small observation has been that we tend to bring cases which are by and large non-preventable deaths, and in which the entire system has worked its best, and so that nobody can point a finger towards my lack of ability to manage the case well. In fact, the most important things that we are going to be able to learn from is to be able to make it comfortable, to be able to share our errors, and to be able to say that, okay, this is what we've learned from that. And that has been the trend for the past 2 or 3 months, when people have actually come out and said, "Look, in the early parts of our COVID experience, we had mucormycosis, we messed up with the electrolytes, and then we learned, and then we immediately rectified." So that was a great way to go, that we accept what went wrong and then we share our story as to how we can make it better. Final words from Dr. Kuldeep, sir.
Just to add last point, this is now in the era of super specialty. A urologist doesn't know what a head injury is. A radiologist doesn't know how to manage a kidney problem. A neurosurgeon doesn't know how to manage diabetes. So this is the only platform at our institute where unknowingly we learn, become a complete doctor. Otherwise, in this era, super specialty has a limitations. That is a barrier to learning other disciplines. Perhaps this is the unknowingly I learn a lot just listening to the people presenting here.
Dr. Abhishek.
Sir, excellent start to the year. Just 2 quick points. I think as teachers, a concept over a period of time, which is an age-old concept and has been a little less underlined, is the concept of primum non nocere. I think we should continuously also underline it. First, do no harm is one of the guiding principles of management. The other is, I would love to ask from Sharma sir again, that now there is a dichotomy between finger pointing and assigning a sense of responsibility, ownership of a patient to residents too. But I think I'll take it up with Sharma sir at tea time.
I think this is very interesting. Our panelists have answered a lot of things and a lot of suggestions and comments also. I will lastly share some of the few points, because we discussed that we should finish it by 8:35, but now it is around 8:38, so that enough time is there for discussion, because there are people who are sitting at the back. They may have a lot of questions, but they don't feel comfortable coming forward to ask those questions. And one thing I would like to say, that we usually, Dr. Garg usually come 5 minutes before the CGR, CPC or mortality, anything. And then at 8 o'clock exactly the things start. So it often happens when the morbidity or mortality clinic is there, we already don't know what has happened, because in 5 minutes the case presentation is finished. So you're just 2 minutes and it takes away a lot of your learning. If you have 5 minutes, it takes around 50% of your learning. And if it is 15 minutes, almost gone. So we have to strive for that. That is very important, critical. And that is also determining about the timeliness of the CPCs, that they should start at 8 o'clock and finish at 8:35. And so the faculty residents have enough time to go to their work, because this is a constraint. So how can we make it more effective? And the purpose is not to load you with the data. And as suggested by the honorable panel, that we have a this record of all the CPR and all the recordings of that. So that is a good thing. We have also attendance of each and every faculty, every resident. Even we have introduced something like credit points, because we are just waiting for the National Medical Commission. So they are going to come out with the CPT credit hours. And this becomes very important for the learning. That is not for any regulatory purpose or give you punishment, but it is just to enhance the learning. So the challenges we faces during these clinical grand rounds and the mortality meets is attendance and the relevance of the topic. But now at AIIMS Jodhpur, we have much improved in that. So there is no problem in that. So there is no poor organization. There is a very, very well organized. Presenters are also having very good teaching skills. They are mostly the patient-centered. So these are the challenges which have been written in the journals about the clinical round happening at other places. They are monotonous or boring sessions. Busy schedules interfere with the commitments and the clinical duties. Declining relevance to the subspecialty practices. Unappealing subject. Lack of participation by the departmental leaders or faculty. So these all are being proved wrong today. Little interaction between the presenters and attendees. I can agree with some of these points. lack of punctuality is one of the important thing. So by the time you have come here, the back benchers and other people, this is already was finished what we are talking about the back or the past. So objectives are, that is, these are some of the objectives like diagnosis and treatment, medical research, collegiality, continuing medical education credits, educate residents, faculty, departmental announcements, mentor residents, highlight the expertise of the faculty. So we came to know about the plastination and the museum and available in the anatomy or the other technology which is available in the other department from the presenter only, from the attending this type of activities. We can also showcase the department to other residents of the other department. This will improve the cross reference and referral to your own specialty also. Duration should be not more than 30 to 35 minutes. Should be enough time for discussion, shorter the better. It should be based on the need, common interest, which is for heterogeneous, because interns are also here. Although this attendance will be taken as a attendance for the interns. So if they are absent, they will be marked absent. Level of presentation to be suitable for the junior resident even. So that is, it should not be very high-fi or very topics which is out of like thinking of the common junior resident of a MBS level. So these are some of the aspects which we have already highlighted. You can go to the YouTube channel and you can see all these cases which have been recorded and presented. Any recent advance in the specific field can also be highlighted. Integration is encouraged, and as said by today's panel, that is a lot of things. A lot of words have been uttered by this panel. One is the quality improvement. So apparently it appears to be quality improvement, which is a very small word. But quality improvement is the biggest thing which can be done in the healthcare system. If you know about the PDSA cycle, plan, do, show and act, study and act. So PDSA cycle can help in doing a small changes every day. And we have to have the micro burst teaching and learning. So combining various teaching styles and methods in burst, improve the learning and also enhance the engagement of the participants. It also maximizes the learning process, is exciting, fun and motivating for both presenter and learner. And we have a highlight, you can see some of the YouTubes. They have done a lot of innovative methods of doing this panel discussion. Two speakers talking across in a debate form about some of the case. Mortality meet being discussed as a panel discussion. So no finger is raised to the presenter. Another research activity has been, this activity has been proposed that we can have a research forum, which is not a thesis or viva or defense. It is to familiarize the institute members, faculty as well as residents with the available techniques and methodology in the institute and encourage the cross-disciplinary collaborative research. So department can choose their own topics, completed or ongoing, and they can present some of the part so that it will stimulate the interest of the other. Any activity, although in the CGR they are presenting the departmental clinical work and highlighting with the statistics how many cases they have done, how much improvement has been done in the quality of care. But also this is a thing which can also be considered, and we are just proposing along with the direction of our executive director is one of the sessions can be there in the form of a research forum. We are circulating these documents to you. So these are all things which can improve and we can help in improving our learning. With the panelists, they have said a lot of things, and I think from the faculty members, senior faculty members, we can learn lot of innovations, their experience also. And attending this CGR, CPC mortality meet goes beyond the routine classes or routine attendance, because here you are talking with each other. You are sharing some of the important aspect during the tea time. So I will not stand between you and tea. So 8:45. So we can wind it up and we can have the discussion during the tea time. You can interact with the other faculty members, other colleagues. Interdepartmental communication should be increased. So I think for today's starting this institutional activity with this like food for thoughts. They are not regulation. They are not demeaning you or not causing any harm to you, but they are just to stimulate the learning and improve the patient care. And we should move towards more excellency in our care. Thank you, sir. Thank you.